Good morning, one and all. I'm a non-research clinician based in Portsmouth. So what I want to talk about in terms of talking about glucose variability is not to talk about oxidative stress and all of that sort of stuff, but to talk about what we can do in our routine clinics looking at managing glucose variability. So there are many definitions of population glucose variability. The challenge is, whilst they all have mathematical value, the clinical value of those huge numbers of different variability measures, so MOD, MAGE, LAGE, CONGA, you name it, they don't really help us in the clinic. And in the clinic, what we recognize is two forms of glucose flux, if you like. We recognize the difference between one day and the next, which is commonly called variability. But of course, we also notice the flux that happens across a day. So fasting is always better than evening or vice versa, which for the purposes of terminology anyway, we should refer to, I think, probably as instability rather than variability. Variability, as I say, this issue about day-to-day change. So I feel a bit like Donald Rumsfeld, because variability by definition is variable. And so you end up with this known unknowns and unknown unknowns process. But of course, looking at glucose variability as a snapshot, by definition, doesn't tell you what has been going on over time. So glucose variability is both something that happens now, but also something that happens over time. We know what makes me feel better today or better tomorrow is the things that I do today or tomorrow. So at one level, the causes of variability we all know, which is it's about behavior change. The causes of instability across a day are often about therapy mismatch, but the causes of variability are usually about different behaviors on different days. And so the challenge is, how do we work those processes? Because what we know is that variability is important in the clinical management of diabetes, not because of oxidative stress, so that may very well be a very important element, but because of the havoc it plays in people's lifestyles, trying to actually manage on a day-to-day basis otherwise. So, how do we bring that forward? So this is a favourite slide of mine, which I think destroys our practice for the last 20 years. If a patient asks you a question, which is better, a hemoglobin A1C of 7.1 or 6.8, what's the answer? The traditional answer, obviously, is 6.8. But the challenge with that statement is that we don't see the entirety of someone's glucose experience through the A1C. The person on the left has an A1C of 7.1. The person on the right has an A1C of 6.8. But none of us in this room would want to be the person on the right, would we? And equally, variability isn't just something, although I, like the speakers in this meeting, spend most of my time looking at type 1 diabetes care. Variability is by no means something that is only a type 1 diabetes issue. And if we've learned anything in the last 10, 15 years following UK PDS, it's this idea of how much more aggressive we need to be early in the disease process for type 2 diabetes. So in type 2 diabetes, the question might actually be not is it 6.8 or 7, but is it 6 or 6.2 that we should be aiming for? Now, of course, all of us are thinking, oh, it's a toss-up. Which way round is the slide going to be next? And that's largely the point. We do not know which is better at an individual level. We know which is better at a population level, but not at an individual level. And we treat at an individual level. As it so happens, the pair I've got here, 6 is by far better than 6.2. And if you had to choose any of those profiles not to have, it would probably be the 6.2 profile. So what's clear then is that whilst overall exposure to glucose, which we measure by mean glucose or hemoglobin A1C, is an important element in outcome determination, it is not the only element. And we have to, as well, take into account the issues around glucose flux measures, which I've already talked about, this idea of variability and instability. Because, of course, logically, hypoglycemia, which we all talk about as being the biggest limiter to our ability to offer better overall control, doesn't relate to the target of the control, unless the target of the control is hypoglycemic. Hypoglycemia relates to these variability measures. And if you don't believe me, I want to show you data from probably the two biggest studies that we have in type 1 and type 2 diabetes. So DCCT, my apologies, ACCORD on the left there, which shows the relationship between hypoglycemia in that study and the achieved hemoglobin A1C. And it doesn't matter whether you were in the intensively treated group in the sort of dirty brown colour or the conventionally treated group in the green colour, the relationship between achieved A1C and hypoglycemia risk was the opposite of the relationship that we see in type 1 diabetes in DCCT. A1C does not drive hypoglycemia risk. Glucose variability drives hypoglycemia risk. The inference being that in type 1 diabetes, the level of glucose variability across the population was fairly similar, whereas in type 2 diabetes, those people in the worst overall metabolic control were also the individuals who had the highest glucose variability. So, we've already heard from Path, A1C is not a useful thing to look at in terms of variability. Now, interestingly, SMBG, which we've sort of not talked about really very much at all in this meeting so far, you can use to measure variability. But you need to be very clear about how you use SMBG if you're going to use it to measure variability. But there are a number of studies, both in outpatient populations using generally fasting glucose variability as a measure of outcome risk, with a very close association with those outcome risks. And in particular, those of us that keep an eye on our intensive care colleagues and looking at glucose control in intensive care will know that the debate around intensive care-related glucose risk in the last 4 to 5 years has moved almost entirely away from the average achieved to measures of glucose variability on the intensive care, with very good data sets around how we can improve outcomes in intensive care by reducing variability. So, the key is that recognizing a continuous glucose measure is the way to determine variability. So, continuous glucose measures have been around for a decade and a half in realistic terms, but until the last 4 to 5 years, they were largely research tools that most of us in routine clinical practice wouldn't have been actively engaged in use of. But certainly the last year, but more realistically the last 3 or 4 years, they're now a routine part of our clinical use. So, our job as clinicians isn't to understand how they work. Our job as clinicians is to make sure that we understand whether a particular device is likely to be reliable in its measurement processes or not, but also then to help the individuals with diabetes to manage that data stream. So our job is data stream managers in that respect, not as technologists. And I think there is this belief that to be interested in glucose variability, you have to be very techie. You do not. There are a number of questions that are tricky to answer about variability, the key one of which being what's normal. When we have a new measure, it's difficult to work out what we're trying to compare it against. This is actually a really large study. It doesn't immediately show how large this study is when you look at 5 graphs, but this is probably over 5,000 people's continuous glucose monitoring data, done as a series of population graphs, looking at one measure of glucose variability, this thing called the percentage CV. The percentage CV, even for us non-mathematicians, is easy. It's the standard deviation divided by the mean for an individual data set. Top left graph shows us people with type 2 diabetes on no therapies for their diabetes. And what we can see is that nobody, independent of their level of control in that group, has got a variability measure greater than this so-called 36% CV. Middle top graph looks at people on, if you like, sensitizing agents, metformin, DPP-4. And what's interesting about that group is that actually the variability measures, if anything, are slightly narrower in that population than they are in people on no specific medical therapy. However, once you start on the top right looking at sulfonylureas, you start to see higher levels of glucose variability coming in. And at that stage, you see approximately 10% of the population with the variability above this 36% CV mark. On the bottom of this slide is the same data for people with type 1 diabetes. My apologies. The same data for people treated with insulin. On the left, people with type 2 diabetes treated with insulin, and on the right, people with type 1 diabetes treated with insulin. And what we can see is that the key is that as soon as we start using insulin, the variability measures shoot up, which is where our challenge comes in. Why do people with type 2 diabetes in the worst control have most hypoglycemia? Because they're the people we give insulin to, and therefore they have higher rates of variability than the other population. So you've seen a number of graphs looking like this already. And the challenge with this graph is we can't manage this data stream. None of us has got a big enough brain to manage this data stream. It's too complicated. So for us to be able to manage the data stream, we need a simpler way of looking at it. And the way that has been agreed that we should look at it, which doesn't appear to be doing, oh, there we go, is this process, the AGP, the ambulatory glucose profile. And what in effect this is trying to do is to simplify a very complex data stream into something that is able for us to make clinical decisions about, recognizing that our role in consultation is often a summative role, not an immediate management role. We think we are charged, don't we, in our clinics with, here is an individual whose A1C is 9%, if only I could help this person get their A1C down to 8%. And that's what we consider our job. The challenge is we get distracted when they talk to us about a hypo they had last week. And so we talk about the hypo, not how can we actually address the A1C. The AGP is aiming to do the long-term addressing because it's deliberately leaving out, and you can see with this overlay, it deliberately leaves out the highest 10% and the lowest 10% of someone's data. So if someone asks you about their hypos, an AGP isn't a great tool to do it. But if you're looking to do that routine job we do in our clinics, the AGP is the perfect tool for it. So we want to try and become familiar with it because it is now an internationally recognized standard. It's not an internationally recognized standard relating to company A, company B, or company C. It's an international recognized standard relating to all measures of continuous glucose data. So if Google's contact lens works at some point, then this is how we will be looking at their data. And it allows us to look at data simply, to make a rapid assimilation in front of the person with diabetes, and it allows us to describe all the elements of glycemia, not just exposure. It allows us, because it takes out some of the outlier data, to not get distracted by outlier data, and it allows us to be objective. But actually, for all of us in this room, the most challenging thing about the AGP is that it is a picture. It isn't a number. And in fact, once you've validated the AGP as a picture, the numbers no longer matter because it's about managing the dynamic, not managing the specific. This is just a representation to say this is last year, this year data, and we can see that the same data is being presented in a wide variety of platforms. This is the de facto norm for this prospect. So we need to get familiar with how to use this in our clinics in the same way that in the 50s, our cardiology colleagues need to get used to how to use an ECG in the clinics. So my brief is to talk about variability. So what does variability look like? So I think this pretty clearly shows what variability can look like. The wider the profile, the greater the day-to-day variability. And of course, what we're able to see is not only where the variability is greatest, but where the exposure and variability is greatest. We'll come back to this. But of course, as I said, variability doesn't just happen in the 2 weeks before somebody came to a clinic. It happens continuously. This is 6 months worth of glucose data. Actually, Jerry might know this slide quite well because it came from the Replace study. This is 6 months worth of continuous glucose data. Represented, each line is a single day. The most recent days are on the right-hand end, and the rest of the 6 months is working across the slide. What's very obvious is if we only looked at the last 2 weeks' data, we would have little idea why this person's A1C is 10%. When we look at the entirety, it's very clear why their A1C is 10%. But here's the challenging statement. This person doesn't need a therapy change. This person is completely able on their usual therapy to achieve near their target goal, but routinely doesn't. That's a very powerful thing to be able to say. This is another interesting pattern that we sometimes see. This person on a day-by-day basis has got very similar variability levels in terms of the instability across any given day, but with a wandering median. So it just depends where in the cycle you see this person, if you were looking at their AGP, to say, am I happy or unhappy today? No therapy changes during this process. So I think as a clinician, I think case presentations always help to try and bring out information like this. So I want to present an exemplar patient. So he's a 55-year-old man with type 2 diabetes, which he's had for 8 years. 3 years ago, he had a coronary angioplasty and stent because he had an end-STEMI. He's managed in that 3 years to get his BMI down from 34 to 29, so doing really well with the dietary manipulation. He is at present treated with a combination of basal insulin, metformin, and occasional short-acting boluses. Effectively, he went on Digami around his MI and sort of dropped the routine bolusing later on as he started metformin. He's got an A1C of 7%, and he's had an A1C of 7% for the last 2 years. And he's a good boy, takes his blood sugar levels before he gives his insulin and before he drives. No sign that there's any issues around hypoglycemia, no sign that there's any problems in his day-to-day management. That's his profile. His A1C, as you can see, is indeed 7%. But is this, for somebody with cardiovascular risk, an optimized profile? We don't know. We haven't got the evidence base to say that absolutely. But I would suggest that maybe it's not. And so what I want to do is to look in a little bit more detail at what we can see on this profile. Why does the profile look not at averages but at medians? This is something we all know from our clinical practice, because when we look at, again, I mentioned fasting glucoses, and again, I have to thank Jerry for this slide. When we mention fasting glucoses, we can all look at this data set and know what the usual fasting glucose is. But what an average would tell us is that the average is 8. So if we were titrating insulin based upon an average, we would be saying we should be increasing this person's basal insulin. But clearly, that would be bonkers, because the usual fasting is more like 4.5, which is in fact exactly what the median tells us. So the challenges with using averages and standard deviations for individual patients rather than populations is that when we do it in individual patients, averages and standard deviations will tend to increase the importance of outlier data. It may well be this person absolutely knows why in the last month he's got 3 very high fasting glucoses. And it's got nothing to do with his treatment. It's got to do with 3 very good Saturday nights, for example. Does that mean his treatment should change? No. So back to this chap. We're looking to be able to see all aspects of this person's risk. This one picture quickly shows us all of them. Area under the median curve tells us the exact same thing mathematically as the hemoglobin A1C. It tells us it only for the duration of the data collection, in this case 2 weeks. But actually when you do 3-month data collections and look at them as an AGP, the area under the curve calculation is almost identical in most people to their measured A1C. We've got 2 measures of variability. The interquartile range, which is the dark blue on the graph, and the interdecile range, which is the light blue. The interquartile range tells us about half of this person's entire glucose experience, or if you like, where their sugar levels usually are at that time of day. The interdecile range tells us about another 15%, or if you like to think of it in days of the week, about 1 day a week either side. So in other words, where the sugars sometimes are at that time of day. The difference between usually and sometimes is often the difference between how a therapy is applied and a behavioural change. We can also see instability across the day on this profile. Importantly, however, the instability that we see on an AGP is not the same as the instability that we see on an individual day profile. For the line to fall, as it does between about midday and 2 on this data, it has to be falling at least 50% of the days during the data collection. The median only moves when it's more than half of the data moving in that direction. And in fact, what we can see for that particular time of day is it's not just one of the 5 lines that moves, it's all 5 of the lines that move. So what we can pretty much say for this individual is between midday and 2, wherever the glucose level is at midday, it will be 3 or 4, 4 or 5 millimoles lower at 2 p.m. That's a very powerful thing to be able to know, because that tells us there is a clear, regular mismatch at that time of day. We want to know about risk periods, and of course they're very easy to spot. Risk periods, if someone is using CGM intermittently, which we can argue the toss about at a later time, but risk periods would clearly give an idea when this person might wish to be looking more closely at their glucose levels. So, we need to become experts in this process in the same way that our cardiology colleagues needed to become experts at looking at ECGs. Because actually in medicine there are many, many different picture interpretations. And actually our picture interpretations we often think of as our most accurate investigation tools, but we never think about the numbers behind them. The AGP is the same. So, what are the principles? Well, fortunately, we know the principles because our radiologists learnt them all ages ago. Take a structured approach to looking at data. Work from a simple principle. View the data in a common format. Radiologists always like to look at PA chest x-rays, don't they, rather than AP. Ensure the information is linked to a problem that's going on at the time. We interpret an ECG differently if someone has chest pain than if they don't have chest pain. Ensure that we validate the data before we try and treat the picture as a picture. That's probably the key statement. And all of those steps effectively are validation steps. Once we've validated the picture, it's a picture, numbers no longer matter. In the same way, you never go to a brain MRI and say, oh, that looks like a temporal lobe lesion. I wonder what the numbers were that produced that round thing in the temporal lobe. And of course, what all visual interpretation is based upon is a skill we all learned about the age of 5, when we first got that pair of pictures saying, spot the differences, spot the 5 differences. Now, we're actually all good at that, and it's a skill we've honed over time. The only challenge with doing visual interpretation of medical images is that you hold one of the images in your memory, which is your perceived norm. Once you've done that process of comparison, then we can start to use all the years of experience we have combined together in this room to make sensible clinical decisions, but only when we've done that process. So, You've seen data like this before. We saw some of it yesterday. We've already seen some of it this morning. This is an amalgam of about 3 or 4 talks that went on at this year's ADA, saying what is normal or what is an idealized profile for somebody wearing CGM who has diabetes. About 70% of the data we'd want in a target range 4 to 10. Internationally agreed target range 4 to 10, or if you're looking at closed loop studies or if you're looking at pregnancy, as we saw yesterday, 4 to 7.8. Less than 5% of the data below that target range, and ideally none of the data below 3 millimoles, because 3 millimoles is the point which we are now definitely calling a definite hypoglycemia experience. And less than 10% of the data above 14 millimole. So that's what it looks like. And it's actually entirely predictable what it will look like through those statements. The AGP, which is 80% of someone's data, effectively is aiming to try and fit inside their 4 to 10 target range. So key statement, we should always look at AGPs against the 4 to 10 target range, which irritatingly, for those of us that just use software as it comes out of the box, is not the target range that any software puts onto your graph. But if we treat it as a picture, it also becomes clear how we treat our individuals with diabetes. This profile, the job as a picture is get the blue area into the red area. And we can't do that whilst the blue area is that shape. So it gives us a logical process of how we need to proceed. We need to, first of all, make it narrower, reduce the variability. In this case, the majority of the variability is 1090. There's a behavioral thing going on that we need to look at and determine what it is that's giving that variability. Even when it's narrowed, however, it still won't fit because we need to flatten it out. We need to improve the stability. In this case, there's a very clear period of about 8 hours of the day where there is upward instability on all 5 lines. There is a therapy mismatch for 8 hours of this person's day. We can manage that quite straightforwardly. And once we've done that, we can bring it down safely. Now, in type 1 diabetes, if you do steps 1 and 2, you almost never need to do anything to achieve step 3. And the reason is very few of our individuals treated for type 1 diabetes are actually on too little treatment. They're on treatment which is at the wrong time of day for their needs on that day, not too little overall. In type 2 diabetes, there often is a need to add treatment to bring the profile down. Quick example. Police officer, type 1 diabetes for a long time, has retinopathy hypertension, generally keeps a pretty good A1C, slightly better than our national average. No problems with hypoglycemia. He's on basal bolus MDI. He's actually managed to have done 2 intensive treatment courses. He did Daphne and Jigsaw, but there we go. And he's on fairly standard doses of insulin. Transformative impact of data. Here is his profile. So it's exactly agreeing, in fact, with what we've just seen. So our job is to, here's a bloke who for the last 5 years has been doing this. Where is the part of the day that we can offer advice and input as an observational process? There's obviously stuff going on through the day where variability kicks in. Where does the variability start to kick in? It starts to kick in after this point. This is the intervention for this person. This person is an early riser, has a 1 for 10 dose with his breakfast, which is very consistently not enough for his breakfast, spends the rest of the day higher. The reason his variability goes up is he's completely aware of that and tries to spend the rest of the day correcting it. What do we need to do? Change his insulin carb for breakfast, and we'll get that. This is 3 years ago. His traces have never looked different since. Very simple change that we couldn't see because we couldn't see the data. A more complex lady, last one I promise, 38 years old, again long-standing type 1, has got weight problems or has weight problems from her perspective anyway, and fibromyalgia. So only eats 2 meals a day because it'll help her to lose weight, won't it? Is on a basal bolus regimen, Lantus Novorapid. Last A1C about 9%, which is largely where she's experienced it. She's concerned that when she eats, her sugars change. She's tried low carb diets, and that hasn't helped, or at least she doesn't believe it's helped, but she had more hypos. That's her profile. What's the issues that we can see on this profile? So there is quite a lot of variability, isn't there? That's never going to fit in a 4 to 10 target range. But there's also 2 very distinct periods of instability. What I want to just do is to give you some of the potential for this technique. She's got 2 meals a day. There they are. Didn't need me to tell you that, did you? That's obvious when her meals are. But the patterns you see with her meals are slightly different. If you look at the sort of 4 or 5 hour process, what you can see is for breakfast, her glucose does get back to its baseline. For the evening meal, it never does. So for breakfast, the problem is a dose timing issue, whereas for the evening meal, the problem is a dose issue. But in summary, I think for us in clinical practice, glycemic variability is what we have been practicing for the past 20 years, but we've been kidding ourselves that it was A1C that we were interested in. It can now be readily assessed and simply and quickly, but we need to then become experts in this visual interpretation tool, which is a challenge because it wasn't there in medical school like it was when we had to learn ECGs. And I think the key is that if we get good at this, then we are truly ending up doing our jobs more effectively for people with type 1 diabetes.